Hi everyone, very good evening guys. I hope I'm audible and visible to all of you, and welcome back. As I told you a while ago, it's going to be a power-packed session because we are going to discuss systemic pathology, and that has endless number of systems. So I've decided, in order to avoid any repetition, because we recently had a marathon a while ago, so I've decided to pick up on some new topics and also some topics which you guys usually tend to ignore because you keep procrastinating it between different subjects. Like thyroid tumors, it's an overlap between surgery and path. Then you have ovarian tumors, gynae path. So same way for nephrotic and nephritic syndromes between medicine and path. So the things that we keep playing around from one subject to another, it's time that we sit down and we study all the images and important points with all of those. I hope you guys have revised yesterday's session. The PDF was shared, so don't worry about the PDF today also. It will be shared on the Telegram group. So just focus on revising with me because your exam is near and revision is what is most important at this point of time. So yes, on that note, let's begin. There was a question which I posted for all of you today morning so that you could just know what exactly were we going to discuss, and I realized most of you, in fact 99% of you, gave me a correct answer. We'll start from that question, where you had a middle-aged female who presented with a swelling in the anterior neck since 4 years. So there was a long duration with a slow growth which was moving with deglutition. As soon as they say moving with deglutition, definitely thyroid is what they're wanting to tell you. FNSC shows a microfollicular pattern. A diagnosis of a follicular neoplasm was given and excision was advised. Excision shows a well-encapsulated tumor with no breach in the capsule, no vascular invasion, and the patient is euthyroid. This was a classical case of follicular adenoma. So I think everyone knows, to differentiate an adenoma from a carcinoma, you have to look out for two very, very important criteria, and that is exactly what I've got for all of you today. We are going to get back to our very favorite tables. So these are all the 4 carcinomas that we have in the thyroid, a quick review of the genetics and all the pictures. Let's begin and then I'll come back to that question. So first and foremost, the most common carcinoma, not only is it the most common, but also the one which has the best prognosis, is papillary carcinoma thyroid. What are the histories they'll give you? Either they'll give you a prior history of radiation that the patient had, or a prior history of Hashimoto's, or their favorite mutation, that is BRAF. And if they want you to answer something in detail, it will be the BRAF V600E mutation, guys, that is going to be there. So remember, BRAF V600E, their favorite most question for papillary. What are the images? Let's do a rapid review as a flashcard for the images. These are the 4 pictures that you have to know. The first one, look at the nuclei. The nuclei are totally empty, so we call them after that cartoon character everyone knows. They are known as the orphan ani, total white nuclei, most famous picture of your exams. Next, if you look, the nuclei have a dot inside it, so that is the nuclear inclusions. They have intranuclear inclusions. Then they have lines in the nuclei, which makes it a coffee bean appearance. And finally, everyone's favorite calcium body, Samoma body. So all in all, I realize it's the nucleus which is going to be very, very important. Without seeing this, I'm telling you again, without seeing nuclear features, never make a diagnosis of papillary. Orphan ani, nuclear inclusions, and coffee bean nucleus. Coming back, this along with BRAF mutation, papillary carcinoma sorted. Now let's go on to follicular carcinoma. First, they will ask you what is the mutation that you see over there. The most common is the RAS mutation. How do you do the diagnosis? You have to look out for 2 invasions that I've got you over here. Number 1 and number 2, let's zoom into it. What are the two invasions that we have for follicular carcinoma? And that was your question. If you have to give a diagnosis of carcinoma, number 1, you should see that something is coming out of the capsule. Very classical. See, the capsule over here and here is broken. Something is coming out of it. Capsule has been invaded, point number 1. Next, there's a full blood vessel which has been invaded, point number 2. So if these two things are present, you call it a follicular carcinoma, and if these two things are absent, then this means it's totally benign. This is a follicular adenoma, and that is what I had asked you in your question, guys. In your question, if you read, this patient did not have any vascular invasion and did not have any capsular invasion. That is why I gave the diagnosis of adenoma. And exactly which is the next question which all of you are answering. Which of the following tumors cannot be diagnosed on FNSC? Their favorite most question. It's the same follicular thyroid cancer. It's obvious, guys. If I have to look out for capsular and vascular invasion, I cannot do it with the help of a tiny little needle. FNSC will never ever help me in the diagnosis of this. I will have to do a surgery only, of course. So the only thyroid tumor where FNSC is a pitfall is follicular carcinoma. You cannot diagnose it on a tiny little needle because you have to look out for these two things. Coming back to your slide, what is the next thing that you're going for? Everyone's favorite, medullary carcinoma. So first tell me, what is the tumor marker for medullary carcinoma? We all know tumor marker is going to be calcitonin. Levels are elevated, and as soon as we say calcitonin, the amyloid which we studied yesterday in the marathon is ACAL. ACAL is the type of amyloid, and as soon as I say there's an amyloid, what is the microscopy that I'm going to show you for amyloid? We did that yesterday also. So as soon as we say ACAL, means we are talking about medullary carcinoma thyroid, and this is the polarizing microscopy for amyloid. And you guys had told me the stain yesterday only, that was Congo red. Congo red showing you that beautiful apple green birefringence. Yes, everyone knows. So now we are linking that general path with systemic, and we are sorted. But we are not sorted in terms of the genetics. Medullary carcinoma has what genetics? There's a RET mutation and there's a MEN2A, MEN2B gene or a syndrome that is involved. Do you all remember how we used to learn it? So for those who've joined in new, I'll let you know, you have to learn, go back to school and learn a little bit of nursery rhyme with me. RET10 med men. If you learn this, you are sorted. What is RET10 med men? When you're talking about the RET gene, it is present on chromosome number 10. The tumor that it causes is medullary carcinoma of the thyroid, and the syndrome with which it is associated is MEN2A, MEN2B. RET10 med men. Please remember this, because the same RET, and this time I put it in pediatrics. Where else do you study it in pediatrics? If I say there is a loss of function of RET, in pediatrics, what is the disease? So function is lost, ganglion cells are lost. What is that condition in which the ganglion cells are going to be lost? That is Hirschsprung's disease. That is going to be Hirschsprung disease, another very important question in pediatrics that you get. So simple, if the function is lost, ganglion cells are lost. Patient is going to have Hirschsprung's. Coming back, this was RET10 med men, which everyone has revised. The last thyroid tumor is anaplastic. It's the least common and the worst. So the history always comes in one classical word. Whatever happened within 6 months aggressively and has resulted in the death of the patient. There's a thyroid mass which has enlarged rapidly within 6 months and has turned out to be fatal for the patient. Classical history of anaplastic. I hope everyone's clear with all of this. Yes, we've done the 3 cancers. So now if I ask you, go back to the first question, that was sorted, we've discussed it. Second question was which cannot be diagnosed on FNSC. You've told me that follicular cannot be diagnosed. Last question. Which is the most common molecular alteration that you see in this tumor? I hope everyone has identified this tumor. It's the classical orphan Annie eye appearance. And yes, it's a case of papillary carcinoma. As soon as they say papillary carcinoma, we go in for BRAF mutation. Everyone make a quick table with me. What are all the things in pathology which are going to show you BRAF V600E mutation? There are a total of 6 things, but at least 4 though you have to know. The other 2 is okay if you know or you don't, but 4 you have to know. What is BRAF? First you write LCH, Langerhans cell histiocytosis, then you read it opposite. Opposite becomes hairy cell leukemia. So LCH, HCl, left, right, left, reading done. Then the 2 P's. 1 P is in front of you, papillary carcinoma thyroid. 1 is a brain tumor, pilocytic astrocytoma. And finally, so these 2 P's and LCH, HCl you have to know. After that, if you can learn it, there's also going to be involvement of colon cancer and melanoma. Colon cancer and melanoma also. But remember, LCH, HCl, P and P, you have to know these. I hope everyone's confident. We've done all the images of thyroid tumors. We can go on to the discussion of the next thing. There's a quick question that I've got, much expected this time, changing the organ. There's a 60-year-old person who's presented with some stomach tumor with the following features. Mesenchymal solitary mass below the mucosa of the stomach with an intact mucus layer. Spindle-shaped cells and epithelioid cells are seen on biopsy. What is the tumor positive for? Multiple choice, the recent trend. Let me know. So what is your option over here? Some of you say A because you believe that all the options seem to be correct. A, B and D is what I'm getting. Okay, what tumor did you think of? Lot of mixture answers that I'm getting over here for the first time. Till now we were all unanimous. There's a little bit of split over here. Tell me guys, so what is this tumor? Very classically they told you it's a stomach tumor. Stomach has 2 tumors, either it's epithelial or it's mesenchymal. This is mesenchymal, very clearly mentioned. If they say mesenchymal, I am only thinking of GIST, right? Gastrointestinal stromal tumor. And these are the 4 markers that are going to be positive in GIST. These are the 4 markers. So quickly revise with me. When we are talking about GIST, what is the mutation that we see in gastrointestinal stromal tumor? It is the c-KIT or CD117 mutation, right? c-KIT or CD117 mutation. And the good news is that the mutation is the marker also. There is a CD117 which is going to be the marker, and in fact that is the most sensitive marker that we have. So mutation and sensitive marker is the same. The specific marker is DOG1. The specific marker is going to be DOG1, and additionally there's another marker which is miscellaneous, is CD34. So now coming back, CD117, CD34 and DOG1 was written. c-KIT is what? c-KIT is the other name of CD117 only. So basically all these 4 options were there. There is not much association with CD99. So that is going to be option 4, 1, 2, 3, 4 were the GIST wale markers. Repeating again, sensitive is CD117 and specific is DOG1. Now you tell me CD99 kahan hoga? There are 2 tumors in pathology where CD99 you have to know. One is a bone tumor, one is an ovarian tumor. So bone tumor is very favorite, Ewing's sarcoma. This question is evergreen. Bone tumor, Ewing's sarcoma, and ovarian tumor, granulosa cell tumor of the ovary. Guys, please remember, in gynae you must have studied, granulosa cell tumor always occurs in old women, post-menopausal women. Granulosa cell tumor occurs in a 99-year-old granny. Not exactly 99 years of course, but when we say granny, we mean post-menopausal. So granulosa cell, 99-year-old granny is how you will learn it, and it also occurs in Ewing's sarcoma. So that's a full question and its discussion regarding this. Let's move on to the next set that we have. Can you give me the answer to this question, which is an easy one I suppose? Gynae-path mixed. 29-year-old female is detected with an ovarian cyst on ultrasound examination and is surgically removed. On cut, the cyst is uniloculated, shows the presence of clear watery fluid. Histopathological assessment is what you have to tell me. Serous, mucinous, fibrothecoma or Brenner? What is your answer? Yes, very easy question. That is serous cystadenoma. I'll talk about the discussion. Tell me one more question first. Then we'll go ahead with the discussion. Again, we have an adult female who's got recently a unilateral salpingo-oophorectomy, which shows the presence of nests of cells similar to the urinary bladder. This ovarian tumor can further show which other component? This is a question I'm genuinely waiting for a lot. I'm waiting for the answers. Okay, everyone wrote D. Guys, did you read the question or did you just go for buzzwords? What did you see? You saw, oh, okay, there's an ovary and acha bladder. Bladder matlab Brenner. I have not asked you that. Did you read the question? Question said, whatever is Brenner, it can show which other component. I was not asking you for the diagnosis of this tumor. I was talking you about what along with Brenner can be associated in gynecology. So the answer to this is a mucinous tumor. See, that is the mistake you do. This question is only to tell you are not lagging behind in knowledge. You are just being very, very impatient while answering questions, picking up buzzwords and answering in 1 second like that. Kacha bladder, Brenner, and I'm not reading. I'm going to go blind towards everything else. Don't do this mistake. This should be an eye opener for all of you, that I'm not going to only pick up buzzwords in the paper, right? On that note, you know what we are going to talk about. We have to talk about these ovarian tumors. This table is my favorite tumor table, because if I learn SSS, MMM and BBB, this table is done. That's all that I have to know. So what tumors are we, and I'll come back to those questions. So for all those who were feeling a little sleepy, postprandial sleepiness was happening, I think that that question has woken up everyone, right? So having said that, what tumors are these? Which family of ovarian tumors are we into? We are into surface epithelial tumors. We are into surface epithelial tumors, and we know from gynecology, whatever surface epithelial tumor they will give me, my tumor marker shall be the same. CA125 for all the surface epithelial tumors. Now let's go into the details. Serous. Serous has everything with S, means how many cysts? A single watery cyst will be there, single watery cyst. Which epithelium? Something with S, ciliated epithelium. Which bodies? Again with S, psammoma bodies. So if they mention in the paper there is a single watery cyst with cilia present with psammoma bodies, you mark serous. Everyone's clear? SSS. So now go for MMM, means if they say there is a multiloculated cyst, not a single cyst, multiloculated cyst with mucinous fluid and mucinous epithelium, they are talking about a mucinous tumor in the ovary. Is that okay with everyone? Yes. Now what is BBB? If they are talking about a Brenner tumor, they are going to show you, like all of you had that buzzword, bladder, urinary bladder epithelium and the coffee bean nucleus. Table ho gaya na? Serous, single, cilia, psammoma. All S's together, mucinous, mucin, all mucin words and multiloculated together. Talking about Brenner, bladder, coffee bean nucleus together. Now the last one. This was the recent INI-CET question. Which is the tumor in the female genital tract because of diethylstilbestrol? This drug has been banned. This drug is not in use, but MCQ examiners love to ask you this question. All clear cell tumors are going to be because of diethylstilbestrol. Now having said this, let me go back to the question which all of you very nicely just ignored over there. So let's start. Many of you are asking me doubts about it. They said this reveals the presence of nests of cells similar to urinary bladder. Yes, we are talking about a Brenner tumor, undoubtedly. This is a Brenner tumor, but that's not the question. The question is, this ovarian tumor, means this Brenner tumor, can further show which other component was asked. So please remember that Brenner and mucinous can occur in the same ovary, and that is why the other component over here was mucinous. That is just to give you an eye opener. Repeating, Brenner and mucinous can coexist in the same ovary, so we'll write a bridge between them. Everyone's understood? Yes? Should we see whatever I told you, this SSS and this MMM, BBB, photos dekh lete hain, then we'll be more confident. Have a look at this. If they show you something like a single watery cyst, there's a single watery cyst, and then can you see the ciliated epithelium over here? I am confident. Single watery cyst with ciliated epithelium, and along with that if they show me the psammoma bodies also, I am very, very confident I'm dealing with the serous ovarian tumors. Coming to the next. If they on the other hand show me multiple locules, if they show me multiple locules or multiloculated cyst with a khali mucin is always going to look a little light. It's not going to look that dark pink and blue. It's always going to look a little light. So everything to do with mucin, that is going to be the mucinous wala story over there. And finally, if I show you this, the classical, look at these nuclei. I've always told students, when you can't understand anything in a pathology ovarian tumor slide, means when, like if I look at this picture, I will never be able to catch it. But neither is it serous, nor no cilia, no mucin. I can't think of any body also. Always try and start looking out for the coffee bean appearance. What you're missing out in an ovarian tumor is probably the coffee bean. So remember, coffee bean appearance in the ovary, which two tumors are going to show it? Can you tell me? Only for the ovary I am asking you. For the ovary, coffee bean appearance is number 1 seen in Brenner tumor and number 2 seen in granulosa cell tumor, both the tumors of the ovary. How will you learn this? No other tumor shows it. So how many of you are coffee lovers? Everyone, there's an ongoing always tea versus coffee debate. So all of you who are coffee addicts, just like I am, which is not a good thing to be. But yeah, all the coffee addicts know that coffee grains, coffee comes as a granular powder and you always brew the coffee. So coffee comes as a granular powder and you brew the coffee. So granulosa cell tumor and Brenner tumor are going to have a coffee bean appearance, right? So even if you are a typical chai lover, but for today you have to become a coffee lover like all of us, okay? Having said that, this was one family of tumors. We are not done yet. There's another family of tumor. What is this? I'm starting with the photos of the germ cell tumors. Which tumor comes to your mind as soon as you see this? And you will just tell me two things, the identification and the tumor marker. That's all that you have to tell me. So I can see very empty looking cells, right? I can see very empty looking cells. What are empty? Fried egg. The fried egg is back in the story once again. So when we talk about fried egg appearance, amazing, we are talking about, okay, this is ovary, so it's dysgerminoma, and if it would have been the testicular tissue, it would have been seminoma. So they will, what is the question that's going to come? This picture will be given, khali, empty cells. They will ask you, what is the tumor marker? What is the tumor marker that you have? Very famous LDH and PLAP. LDH and PLAP are the tumor markers that you have for seminoma, dysgerminoma. One tumor is done. I have a table for this also. Table I'll show you in the end. Abhi, just keep looking at pictures and identifying with me. So LDH and PLAP for dysgerminoma. What is the next one? This is the very famous, you cannot get this wrong ever. This is a very famous body which you know as the Schiller-Duval bodies. The Schiller-Duval bodies, and remember, Schiller-Duval means it's going to be, how will you identify this in the paper? There will always be, there's a way, there should, you know, it's like a rhyme. Repeat with me 2-3 times so that you'll be able to learn it well. There will be a blood vessel in the center. So center is going to have a blood vessel. Then there is going to be a tumor part, then a space, then a tumor. Matlab, blood vessel, tumor, space, tumor, blood vessel, tumor, then a space, and again tumor. So between two rows of tumor cells, I need to have a space, right? Blood vessel, tumor, space, tumor, because sometimes they will not show you this picture. And if you saw the pattern of the FMG exam that happened on Jan 20th, most of the pictures were missing. They had given descriptive information. Something like, there's an ovarian tumor with a blood vessel in the center, surrounded by a layer of tumor cells, surrounded by a space, and surrounded by another layer of tumor cells. Such a long statement will be written. You should know that is going to be a Schiller-Duval body. We are talking about, yes, bachon wala, that is the small kids, yolk sac tumor, and we all know the tumor marker, of course. The tumor marker is again a bachon wala thing, that is an alpha fetoprotein, feto. So yolk sac, feto goes together. Okay, moving on to the next one, the tumor which shows you lots and lots of blood. Which ovarian tumor is going to be all about hemorrhage and necrosis? Lots of hemorrhage and necrosis, in whether it's in the ovary or it's in the testicular tissue. Your answer is the same. It's a case of choriocarcinoma. It's a case of choriocarcinoma, and choriocarcinoma is reminding me of that gestational tumors, right? So if I have gestational tumors, I'm talking about trophoblasts. Two cells are seen, cytotrophoblast, syncytiotrophoblast. Very good. How will I, this picture now, most of the students, let's be very honest, when this picture will come, no one will be able to identify it, and also thanks to the fact that they give us really low quality images in the exam. So we might not be able to guess it. So there will be one tumor marker which will come to my rescue all the time, and that tumor marker is going to be the beta HCG. So first look out for beta HCG levels in the patient, look out for this tumor with lots of hemorrhage necrosis, and then come to this picture. So you will have a cell, there will be a cell which will have only one nucleus, and there will be a cell which will have lots of nuclei. So that 1 nucleus wala is a cytotrophoblast. Look at these 1 nucleus wala cells, and then there'll be a syncytium. Like all of us are a syncytium today. We have all gotten together to study over here. So this syncytium 1 is going to be a syncytiotrophoblast. You see both of these in a choriocarcinoma. The last tumor of germ cell category, I don't even want to discuss it because let's be rapid. We all know we are dealing with a teratoma. There is no query about it. The only question I want to ask you, you can see all that hair, teeth, bone, sabko pata hai. The only question that they're going to ask you is this over here. What is this? This solid area. That is what I'm always worried about. Otherwise, teratoma, even an intern can diagnose. What is the work of a pathologist? To actually look into this solid area. This solid area is known as a Rokitansky protuberance. What is it? Is it a showpiece? No, it's not a showpiece. If I see this solid area over here, I am very worried. I will take my scalpel, I will cut through it because this may or may not have a foci of cancer. As I said, may or may not. So it's like a treasure hunt. You will have to cut it, you will have to see does it have cancer inside it or not. So remember, Rokitansky protuberance has major significance in pathology. Coming all the way back, what did I just teach you? A very quick recap. The first one we did was dysgerminoma, which showed you the classical fried egg appearance, and we had LDH and PLAP as the tumor markers. Then I showed you choriocarcinoma, lots of hemorrhage and necrosis, the two types of cytotrophoblast and syncytiotrophoblastic with beta HCG. Coming to the next, we have yolk sac tumor, which showed you that Schiller-Duval body, and the main tumor marker is the alpha fetoprotein. And teratoma, everyone knows, so we'll skip that once again. Having said that, the next question, do you see another name written for Schiller-Duval body? That is a question that I know. I'll come to your question, Dr. Future Doc. I'll come to that. Schiller-Duval body, what is it also known as? Glomeruloid body. तो एक बात बताओ, this glomeruloid body, where else in pathology, which brain tumor can show you glomeruloid body? It doesn't look like this, it's totally different, but question aata hai, theoretical question. So glomeruloid body, number 1, yolk sac tumor. Which brain tumor? Easy to identify. GB is seen in GB. Glomeruloid body is seen in GB, that is glioblastoma. Very good, guys, amazing. So we are jumping from one organ to another, and all of you are keeping up the pace also, which is super good. So yes, GB is seen in GB, that is glomeruloid body is seen in glioblastoma. All's well. So quickly we finished off this second wala also. So this means your surface epithelial are done, your germ cell are done. Now we are just left with 2 more tumors. First you tell me the answer to this. Where am I going to show you Renkets crystalloids? Very famous. I'll answer that because there might be a lag in the answers. I know all of you have answered Leydig cell tumors. That is the confidence that I have in all of you. So Renkets Leydig cell. Now Leydig cell is obviously a male tumor, but it can occur in the ovaries also. You just need to know how is the picture going to look like. These are going to be, and they have only 1 or 2 pictures of Renkets crystalloids. They don't have too much of variety out here, okay? So this is what you're gonna see, and these are the Renkets crystalloids. As soon as you see these cylindrical kind of things, you are only going to think of Leydig cells. Means a normal Leydig cell can also show it, a tumor can also show it. So just by reading Renkets crystalloids, don't jump to the diagnosis of a tumor hi hai. Look at the patient also. Does the patient have any tumorous lesion, any mass, any swelling, lump mentioned or not mentioned? Because even normal Leydig cells can show you Renkets crystalloids. Is that okay with everyone? So this was a quick question. After that, now you're going to identify, obviously this is given to you, it's written also, this is another body. So 2 bodies are very important. One, you've seen the Schiller-Duval body for yolk sac. Now I'm going to show you the Kohl-Exner body over here. So all of you have identified that this is granulosa cell tumor. We are going to together make a flashcard of granulosa cell tumor because there is a, every word is a question. How many questions should have I got for you? So I thought we'll make a flashcard together only. Every word. So first and foremost, the age. Did I tell you granulosa cell tumor? That is going to be granny. So matlab this is going to be post-menopausal. Granny में होगा तो it's going to be post-menopausal. And I also told you the CD marker. The last part also you know, she's a 99-year-old granny. So this is going to be CD99 positive. And many students who've attended my classes earlier, you know this is one of the most fun stories which never ever goes out of your mind. For the other students, let's help them out. Okay, having said that, so now tell me, what is this granny, this old granny, what has happened? Suddenly hormonal surge has happened in her. She has suddenly started secreting a lot of estrogen, hyperestrogenism. The ovaries have started secreting a lot of estrogen. As a result of which, what did she do? So now she's become, she's on a hormonal surge. So what is she going to do? That is going to be call Exner body. That is going to be call Exner. So because of that hormonal surge, she ended up calling her X. Not a good idea. Not a good idea at all, but she called her X. That is call Exner. How does call Exner look like? Look at this, guys. The tumor cells are all round, and there is some pink material that is present over here. So there are some round cells with pink material in the center. That is a call Exner body. Like I said, she started calling her X, not a good idea. And also, what happens to the nucleus? She wanted to go have coffee with her X. So she basically started showing you coffee bean appearance. Did I just tell you which other tumor was showing you coffee bean appearance? Brenner and granulosa were the two which had to show you coffee bean, है ना? So yes, having said that, all that I said to you, was it a good idea? Not a good idea at all. This process of calling the X should be inhibited. So what is the tumor marker? Inhibin levels are elevated. And finally, what would you want to call this granny who is now calling her X? Very clever. Clever like a fox. Clever, she's a fox lady. She's a clever lady. So what is the genetic mutation that you see? We see the FOXL2 gene mutation. You know every word of this is a PYQ. So there comes a story of the 99-year-old hyperestrogenic granny. So yes, they will say call Exner and coffee bean. She's clever like a fox. So FOXL2 gene mutation and inhibited. All this story should not be there. It's not a good idea. Inhibited. Inhibin is going to be the tumor marker. Everyone remembers it, and like I said, once you hear it, and this story will remain with you even after the NEET PG exam. All said and done. Inhibin A, Dr. Mrudu, that is going to be the ones. Okay, now there are two questions which are pending. I'll first quickly take those two questions. Someone asked me what is the story of OCT and NANOC. So obviously these are extra edge questions for those who are aiming good marks, and I'm sure everyone is aiming good marks. So please remember these OCT 3-4 and SAL4 and NANOG, all these new markers, these are markers of germ cell tumors. Dr. Future Doc was asking us, these are germ cell tumors. So jo dysgerminoma, yolk sac tumors, all of those are the ones which are going to show you all of this. That was one extra question that someone asked. Second, you are asking me, is Brenner's going to be benign or malignant? Brenner has both varieties, benign, intermediate and malignant. So you have to actually look at what the examiner has given you in your information, right? Okay, chalo, all of this is done. Finally, we feel confident. I told you we'll discuss thyroid tumors, we'll discuss the ovarian tumors. Now all ovarian tumors are done, but what if something is coming to the ovary? What if there is a stomach tumor that is coming to the ovary, and we know that is the very famous Krukenberg tumor. So the only thing about Krukenberg tumor that you have to know is the cell. What cell has been shown in this picture? The very famous signet ring cell. Look at it once because it's important. This is a cell and the nucleus has gone all the way at the periphery. Why has the nucleus? Why in your own house will you sit in the corner? Why in your own house is this nucleus sitting in the corner? Because some unwanted relative has come into the house. That is when you will sit in the corner. So why is the nucleus sitting at the corner? Why is the nucleus sitting on the corner? Because some unwanted relative, that is mucin, some unwanted, and I'm saying unwanted relative because right now everyone must be very sick of all those relatives asking you, na, when is your exam and how many more years are you going to study and when will you get married and all of that. So that is the reason that I am giving this information to you. Some unwanted relative has come and sat. That is why you have gone and you are sitting in one corner, right? So mucin is basically present. Signet ring cell is what? what? Mucin is what is going to be present. So all said and done, last 30 days, don't listen to any guest, any relative or anyone. You are doing more than what you can in life, so no one should have the right to judge you or to comment on anything that you are doing. Trust me, they cannot even do 1% of what you are doing. Having said that, yes, ye sab ho gaya. Now there's one surprise element for all of you which I did not tell you that I'll be discussing, but I am going to. And that is this, a little bit of immunofluorescence and skin, little bit we'll touch upon Dermapath. So what is this guys going to be? There is a 20-year-old female who presents with blisters over the skin and in the oral cavity. Her skin biopsy shows a special pattern which everyone has identified. And what is this? Okay, you had to give me a true and false. Everyone started answering. No one asked me kya answer karna tha. So you just started answering. Wait for me. You have to give me a true and false, or you can just tell me that which out of these do you think is false? Easier way out. So everyone's answering two. No guys, what did you think? Okay, wait. What is this appearance over here? This everyone identified. This is the classical fishnet appearance. Fishnet appearance means and plus the lesions are seen in skin and in oral cavity. We are talking about pemphigus vulgaris. Pemphigus vulgaris is a mutation or an antibody against what? Pemphigus vulgaris is antibody against desmoglein 1 and 3 both. So that means what was the only wrong statement over here? The only false statement over here was antibodies against hemidesmosomes. So revise kar lete hain. Little bit revision is needed over here. Let's quickly do it. See, let's start with the two pemphigus first. The one on the left is pemphigus vulgaris and this is going to be pemphigus foliaceus. Foliaceus mein everything is first. Means if you ask me which desmoglein is affected, I will say first. Or if you ask me that which is the layer of the skin that is going to detach, the first. What is the layer of the skin? First layer, topmost layer of the skin, cornea. So subcorneal is going to be the split. So the first desmoglein is affected and the first layer of the skin is affected, that is going to be pemphigus foliaceus. Whereas in pemphigus vulgaris, desmoglein 1 is also affected, desmoglein 3 is also affected, the skin is also involved, the oral cavity is also involved. Matlab where vulgaris is going to be widespread, it's going to have everything and it's going to show you the classical, this we were discussing yesterday also, is going to show you the row of tombstone appearance. What is this tombstone standing over here? The basal layer. Means what's the level of the split? Above the basal layer. It is a suprabasal split that we have. So first you've understood, in vulgaris, suprabasal, in foliaceus, the first layer has split, so it is going to be below that, subcorneal. But what is the immunofluorescence that you see? We see the classical fishnet. We see the classical fishnet. You think examiner is so basic, he will give you the word fishnet. Everyone, even a non-medico can look at this and tell it's a fishnet. Examiner will call it a reticular pattern. Okay? So this you have to learn. This could be something tricky for you in the exam. It's the same as a fishnet. It's called a reticular pattern. This was the question. Coming back. So yes, this is definitely pemphigus vulgaris, desmoglein 1 and desmoglein 3 and fishnet appearance. The false statement was hemidesmosome nahi hota. Yesterday wala tombstone kya tha? Yes, Dr. Divya, everyone. What was yesterday wala tombstone? Some necrosis, coagulative necrosis. Yaad aa gaya? Yes, you've learnt it. Coagulative necrosis also shows you tombstone appearance. Perfect. Now asking you the next question. Where do you see ribbon candy appearance on an immunofluorescence? Where do you see ribbon candy appearance? So this is a classical case of bullous pemphigoid. So at least these two I had ruled out. It can't be pemphigus vulgaris and foliaceus because they show you the fishnet. I have either 2 or 4. So out of these, bullous pemphigoid. Let me show you a picture. These two that we are left with, both of them have something in common. Bullous pemphigoid and dermatitis herpetiformis. What kind of a split do they show you? They show you subepidermal, epidermis ke niche, below the epidermis, they are going to show you the split. So have a look at this. I have a case of a subepidermal split. So you can see the full epidermis has gone off. The full epidermis, it's total detachment. The full epidermis has gone off from the underlying skin. That is a case of bullous pemphigoid. What will I see under the microscope? Can you see these two immunofluorescence? I see a green color line here also and I see a green color line here also. Is the location of the lines different? Yes. Please remember, over here, for example, if this is a bulla, this is a bulla over here and this is a bulla over here, I have to see where is the green color line coming. If it's coming on the roof of the bulla, what disease is it? If it's coming on the roof of the bulla, it is bullous pemphigoid. If it's coming on the roof, it is bullous pemphigoid. And if it's coming on the floor of the bulla, what disease is it? Epidermolysis bullosa acquisita, EBA. Epidermolysis bullosa acquisita. Dermatology questions repeating once again. And how will you learn this? Bullous pemphigoid, God is obviously going to be somewhere up there blessing us for our exam. So God is always going to be somewhere on the roof, somewhere up. Whereas epidermolysis bullosa acquisita, aqua, water is going to be on the ground. So here you have the green color layer which is on the ground. Okay? So God is blessing us from above, from the roof, and aqua, water is going to be on the ground. Both of these will show you the same subepidermal split. It's the picture that you are going to differentiate it, which everyone has identified. Ab ye wala mnemonic bhi hamesha, this will remain with you even after your NEET PG. This will always stay in our mind. Having said that, now bullous pemphigoid story is done. Instead of calling it a line, they called it ribbon candy. Again, everyone has basically, talking about, we'll not go into atheists and all. We'll talk about, yes, God above. So abhi ke liye we'll learn that. And right now everyone has increased faith in God because exam time coming. We've seen Three Idiots and we've seen the movie of how during the exams your prayers towards God, whether you believe or you do not, but your prayers definitely increase. Having said that, guys, if you realize, now there was some scientist who said, no, I don't want to call it a line, I want to call it a ribbon candy. So yeah, they called it a ribbon candy appearance, and that is the same. Okay, having said that, now the next one, where do you see this? Tip lesions are seen in. Tip lesions are seen in, obviously, ma'am, no points for guessing. The only disease left now is dermatitis herpetiformis. So we are ruling out here as well. And let's talk about it. When we talk about dermatitis herpetiformis, classical 3 questions and nothing beyond it. 3-4 saturated questions hai. Again and again they're going to give me those. Firstly, where is the split? This is also subepidermal. This is also going to be subepidermal. So here you can see below the epidermis there is a split. And on that mountain, which antibody comes and gets deposited? On that mountain, IgA comes and gets deposited, and that is known as a tip lesion. So simple. Question number 1 is, what is the split? Everywhere it is becoming. Bullous was also subepidermal. That acquisita was also subepidermal. This dermatitis herpetiformis is also subepidermal. But this shows you what? Question 2, it shows you that IgA ka cluster, that is like a mountain, like a tip. Yes, with which intestinal disease is it associated? Very good, everyone has already answered it. It is associated with celiac disease because celiac disease also has IgA antibodies, and dermatitis herpetiformis also has IgA. So the same IgA is affecting the skin over here, and the same IgA will go and affect the GIT over there. So it's a cross relation that is happening. Finally, what can we use for the treatment? We can use D for dapsone. Dapsone for dermatitis herpetiformis is what can be used. I hope everyone's okay with this question. No confusion? Yes? Okay, let's move on to another skin related question that we have, specific for most controversial question. Why do you want me to get into controversies? But it's exam time, I won't escape from it. Most specific antibody for celiac. Some books say it is endomysial, some people say, or some books and authors say it is anti-gliadin antibody, but anti-endomysial is coming across as more promising. So in case this torturous question comes up, then anti-endomysial can help you. Anti-TTG, for those who are answering, is more sensitive. Anti-TTG, most sensitive. Okay, having said that, let's move on to everyone's next favorite most part, and that is, I think, not so favorite part actually, but that is going to be this. So we are now moving on to the discussion of a lot of renal system which everyone was waiting for. I know I've kept it towards the end, but don't get saturated because a lot of images are going to come your way, right? Okay, having said that, how to differentiate SCC, BCC and melanoma. Okay, I'll quickly tell you that because you asked me a question on skin. So if you've asked me for first you will have to answer my question, then I will answer your question. Tell me this and then I'll start with renal, okay? Multiple basal cell carcinomas is a feature of which of the following conditions? So you answer one, barter system karte hain, you give me one answer, I will give you one answer. So what is the condition which shows you lots of basal cell carcinomas? Basal cell carcinomas are seen in, yes? Okay, fourth option that you're selecting? No, not fourth option. Okay, let's start one by one. क्या क्या लिखा है यहाँ पे? Firstly, Gorlin syndrome and xeroderma pigmentosum. So 2 and 4 basically. These are the ones that are going to show you multiple basal cell carcinomas. पहले तो what is a basal cell carcinoma वो देख लो. Then I'll come back. This is a classical case of a basal cell carcinoma. You will always see something around the face, basically around this area, medial canthus and nose wala area. So you can see the eyes over here, na? So this is that medial canthus and nose wala area. And you will always see one very dilated telangiectatic kind of vessel over here. That dilated vessel is quite characteristic of this particular disease, basal cell carcinoma. So that is how this area, medial canthus, this is the clinical part. Now let's talk about the part which is pathology, which troubles everyone. So you will see cells which are always going to be parallel like this. What are these parallel cells called? They are called as palisading cells. We see the presence of palisading cells. So you can see the cells at the periphery, they are all parallel to each other. Not just that, all the cells, it looks as if there is a separation. For example, if this was the cell, it looks as if it is separated out. Something is pulling the cells apart. There's a retraction that is happening. Very good. This is referred to as the retraction artifact. This is known as retraction artifact. But these three things you have to know. You see a tumor with a dilated kind of a vessel. Along with that, you see these palisading cells and retraction artifact. You are dealing with a basal cell carcinoma. Now coming to what were these conditions. Xeroderma pigmentosum is a defect which can show you skin cancers in general. And that does not limit only to basal cell carcinoma. It can show you squamous cell carcinomas also, and it can show you the malignant melanoma also. So basically all kind of skin cancers are seen in xeroderma pigmentosum. So that I definitely had to pick up. Talking about this Gorlin syndrome, this shows you something very interesting. So first and foremost about Gorlin syndrome, from dermatology you will tell me what is the gene that is defective. The PTCH gene, which we call as patched gene. The PTCH gene is going to be defective, and what are the things that it's going to have? So firstly tell me, in gynae and in ovary it shows you something. In gynae, like I said for Gorlin, in gynae and in ovary it is going to show you something. It shows you bilateral fibromas in the ovary. It shows you gynae ovary mein kya? Bilateral ovarian fibromas. After that, what is it going to show you? You all remember that famous news TV anchor who used to come in our childhood on a very, person who used to be dressed in a very scary manner and used to always shout out, "Gaur se dekho." Remember that anchor who used to give that crime news, "Gaur se dekhna"? So whenever I say Gorlin syndrome, I am always reminded of that Gaur se dekhne wala news anchor, and it reminds me of all the scary stories that he used to portray in a very scary manner, है ना? तो गौर से देखना means all of the things which are to do with the head and neck, गौर से देखना वाला things are gonna come. So I just told you near the eye, the tumor is going to be basal cell carcinoma. Near the eye, it's going to be basal cell carcinoma, and just close to the eye, you have a tumor which is medulloblastoma. This also shows you a brain tumor, that is desmoplastic medulloblastoma. So never mind, for those who don't remember, maybe I am just too old and you guys have not seen that anchor, but never mind. Now you know Gorlin is to do with gaur se dekho, so you have to have something around the eye and the head and neck tumors. So the eye wala is basal cell and the head wala is going to be desmoplastic medulloblastoma, right? And along with that, gynae and ovary bilateral fibromas, so that is Gorlin syndrome. So again, BCC in Gorlin, BCC in xeroderma pigmentosum. I hope everyone is okay with this. Yes? All good, not a problem. Finally, someone had asked me about BCC, so your query is sorted. If they would have given you a case of the other question that you had, a case of squamous cell carcinoma versus basal cell carcinoma versus malignant melanoma, in most of the cases, melanoma will come to you with some kind of a melanin pigmented lesion. Most of the cases, 90% of the cases will come to you with a pigment. For squamous cell carcinoma, they'll show you the favorite picture of a squamous cell carcinoma which they show you, and that is going to be the keratin pearls. I think I have a picture somewhere in my database. If I can quickly solve that query, let me look into it. Yes, I think this is, luckily I do. So have a look at this. Whenever they want to tell you something about a squamous cell carcinoma, they are going to give you their apna favorite wala picture, and that is going to be the keratin pearls. You can see this pink color structure over here. This is the keratin pearls. And for basal cell carcinoma, I've told you right now that they will show you that classical palisading. So basal cell carcinoma to ho gaya. I hope now the question is simple. KPs for squamous cell, palisading for basal, and pigmentation and something to do with melanin for melanoma will be mentioned. Okay, so the doubts are sorted, and we ended up doing another topic with that, thankfully. Now let's come back to what exactly that we have, and any question or query that I might be missing out on because the comments are going quite rapidly. I'm firstly sorry for that. Secondly, at the end of the session, I'll give you all a lot of time so that any queries that I've missed out on, you can type it again and we can discuss. Okay, chalo, having said that, now all of you had already answered it, so jaldi let's talk about this. We are starting with, I'll make you practice questions, but first have a look at all these pictures and revise your details once again. Nephritic syndrome. As soon as I say nephritic syndrome, and the first one that I start off with is the nephritic syndrome in children, that is P for PSGN, P for pediatric, right? So the most common in children, post-streptococcal glomerulonephritis. Kya photo aayega? The first one, the classical, we see the flea-bitten kidney. We see the flea-bitten kidney. Perfect. What does it show? What are these kids looking up in the sky for? They are looking up in the sky for that starry sky pattern. It shows you the very classical. What is starry sky? Everyone knows. You look up in the sky. If you live in a place like Delhi, you will see nothing but pollution in the sky. But in a good place where you might have better AQI, you will see nice stars in the sky. So if you look up in the sky, the stars are going to be shining. So if you look at this immunofluorescence, you will see there is a lot of shining stuff that is happening over here. A lot of shining stuff, and that shining stuff is basically the stars. So we see the starry sky pattern. After that, you see a big mountain. Suddenly a big mountain will be seen on electron microscopy, and that is going to be subepithelial hump. The subepithelial hump. So these three things are together said for post-streptococcal glomerulonephritis. The flea-bitten kidney with the sky that I don't get to see ever in Delhi, that is the starry sky appearance, and we have the subepithelial humps. Yes, below the podocytes. All of you are right. The same story. So what is this PSGN wala bachcha? Tell me a little bit of clinical. What are they going to tell you? They will say that this kid has a sore throat, because obviously there is streptococcus infection, and after that the kid has cola color urine. So kid, basically I'm talking about a child. So there's cola color urine, but all of this will take how many days to occur? 2 weeks, basically 10 to 14 days. That's your clinical history in the paper that you watch out for. You have a kid, 6, 8, 10-year-old kid who has a sore throat, and 10 to 14 days later he has cola colored urine, because now I'm changing my story to the same sore throat and the same cola color urine, but I have changed the age of the patient. I have made this patient into an adult, and I have made the duration of only 3 days. Then tell me what is going to be the answer. Now the age is changed, the duration is changed. Now your answer becomes Berger's disease. Now your answer is Berger or IgA nephropathy, means which immunoglobulin will get deposited. Common sense, IgA will get deposited. In which part? So IgA se to I got to know IgA is the antibody. BE for Berger's, BE for between, the in-between area of the kidney. So for example, if this was, just imagine, this must have been one capillary, this must have been another capillary and another capillary. So not in the capillaries, the area between the capillaries means the mesangium. The mesangial area, so between, remember Berger's mein between wala area is gonna be affected, that is the mesangium is affected. And these are the two questions you get. The same story of sore throat and the same story of cola color urine. In pediatric hoga to PSGN, and adult hoga to A for A, adult is IgA and pediatric hai to PSGN. I hope that is okay with everyone. Very good, I've got an answer. Yesterday we had studied amyloid deposits first where in the kidney? First place of amyloid deposition, even without asking, I've got that answer, which is super good. So what is that thing? Mesangium, na? Amyloid also deposits first in the mesangium. 3 questions. 3 questions on mesangium, nothing more in path and medicine. What is amyloid first gets deposited? Answer, mesangium. Berger's disease shows you deposition in front of you. Berger's disease, mesangium. Number 3, mesangial cells are what? M for M. Mesangial cells are what, guys? They are macrophages. So remember, mesangial cells are going to be nothing but M for M, that is macrophages. Everyone sorted? Because we have finished the entire story of cola color urine. Now if these patients are going to be treated, very good, they'll be fine. They don't get a good treatment or they progress, what do they land up with? They land up with an RPGN. This slide is very, very cluttered, but I wanted to make one flashcard out of RPGN, so it's all put up in this one slide finally. RPGN is what? RPGN is a clinical term, rapidly progressing. They will give you a history, patient is progressing jaldi, but that's a clinical term. For a pathologist, what is RPGN? All the RPGNs, whatever 1, 2, 3 may be written, for a pathologist it is crescentic glomerulonephritis, means a crescent is going to be seen. A crescent or a flap. So my question to you is, what is the composition of a crescent? What is the composition of, it's a flap, like I'm telling you, for example, this is the glomerulus, flap ki tarah, something like a flap is going to be there. So yes, what is the composition? Very good. That a crescent is made up of a flap. Everyone, this is much expected this time. So F means it is made up of fibrin, very good. L means it is made up of WBCs or leukocytes, and P means it is made up of, this is the catch point, it is made up of parietal epithelial cells much more commonly than visceral epithelial cells, because that is what they ask you. Now listen to my question, listen to the framing of the question. Crescent is made up of fibrin, leukocyte, parietal, visceral, all of the above. So you will select all of the above. All the cells are present in a crescent. But if I say fibrin, leukocyte, parietal, visceral, which is least likely to be found in a crescent, least amount or least likely, that is going to be visceral. So that's why I made a mnemonic flap. Fibrin, leukocyte and parietal are the main people in a crescent. Visceral is that very tiny little portion that I have to remember. Why am I reading about crescent? Because if I increase the number of crescents in a patient, I say a patient has 5 crescents, another patient has 50 crescents. As I am increasing the number, the prognosis of the patient is going to become worse and worse. There is going to be worse prognosis for the patient. So here we are back. I have seen the crescent. Now you want to see this crescent and its formation under the electron microscope. What is electron microscope going to show you? The super duper hit movie which everyone loves, that is RRR. What is the RPGN ka? What is the RPGN ka electron microscopy going to show you? Something has broken off. You can see there is a basement membrane. Not only has it like broken off, it has also become wrinkled. So it's like a rubber band. It's not only broken off, it has also become wrinkled, right? So here you have wrinkling of the basement membrane. So we learn in RPGN there is a rupture and there is a wrinkling that is present in the basement membrane. You have to learn this. RPGN is expected. One question of kidney you know is going to come your way, right? So RPGN shows you rupture and wrinkling of the basement membrane. So crescent is done, RRR is done. Now I quickly have to revise these 3 types and nephritics are over. We can practice questions. RPGN type 1 is good pasture syndrome. Means which antibodies? Obviously anti-glomerular basement membrane antibodies. RPGN type 1, GPS, good pasture syndrome. RPGN type 2 is what I was reading right now, that kids wala, that cola color entire story, all of that comes into RPGN type 2. And RPGN type 3, you guys will tell me, this is medicine. There are 2 diseases that come under it. Microscopic polyangiitis and Wegener's granulomatosis. Can you guys tell me what kind of blood vessel disorders were they? What kind of blood vessel disorders? They were posse immune, ANCA wala, very good. They were the posse immune ANCA stuff, right? Posse immune only tells me immunity ka problem hai. Posse means less. So there's going to be less of immunity. So immunofluorescence will show me nothing. Good for me. I don't have to see any picture. Very good. Every disease should be like like this. It is posse immune, it is not going to show me any of these. You know, this is the most common RPGN that we have. Out of 1, 2 and 3, this is the most common RPGN that you have. Talking about RPGN 1 and 2. So 1 looks like a 1. So what is the RPGN pattern that I'm going to show you on immunofluorescence? Looks like L. So it shows you the linear pattern. Look at these pictures. There is no starry sky. The same green color. The same green color has come everywhere. So it's a linear pattern. 1 looks like L, so linear pattern. RPGN 2 shows me two things. Means dark and light, means two things, two colors. That is what? Starry sky. So I have another starry sky appearance. The same shining stuff, the same shining starry twinkling stuff is also going to be there. So someone asked me the difference between PSGN and RPGN. PSGN is the main disease, and in 99% of the cases PSGN is self-limiting and the patient is not going to have a problem. If PSGN progresses, that 1% scenario, that PSGN will then become RPGN type 2. So having said that, a very rapid 30-second revision. When I'm talking about RPGN, it's of 3 types. RPGN 1 is Goodpasture syndrome, 2 has all the disorders read earlier, 3 has M and W, that is microscopic and vaginous. 3 is actually the most common. It has no immunofluorescence, thankfully no picture. RPGN type 1 looks like L, so it shows you linear pattern. 2 has 2, shining dark, 2 things. So it's going to show you the starry sky appearance. All of them are going to show me a crescent. Composition of a crescent is flap, as we have studied. All of them will show me RRR, that is rupture and wrinkling of the basement membrane. Ho gaya, 30 seconds of this are over, which means I can relax a little. I can take a break and you can give me a quick answer to this. 29-year-old male presents with hematuria and mild proteinuria. Serum creatinine levels are raised and histopathology shows the finding over here. What are the causes which is least likely? Yes, again an answer that I'm genuinely waiting for a lot. This is not a question only to judge your knowledge, because knowledge, I'm very confident you guys have like much more knowledge than me also. Knowledge, you guys are bubbling with knowledge. This is just to check how well are you reading your questions. Exactly. So now I think after that ovarian tumor wala trauma that you had, you have started reading questions very nicely. So which of the following causes is the least likely is what they had asked. So what I see in this picture is definitely a crescent. As soon as I see a crescent, I know I'm dealing with RPGN 1, 2 or 3, one of the RPGNs. Goodpasture syndrome is RPGN 1. M and W are RPGN 3. All of these are RPGNs. Which of them is not an RPGN? Least likely. Least likely, and in fact, polyarthritis nodosa. Go back to your vasculitis chapter. Polyarthritis nodosa is very clearly written that it does not cause glomerulonephritis. It does not cause any of these RPGNs. Okay, let's pick up another question. It's a little lengthy, but I think we'll be able to sail through it. Which of the following is true about the glomerular disease depicted in the image? The image has obviously gone to the other slide because it was that RRR wala image, it did not fit into it only. So assume it. They've shown you a case of RPGN. It did not fit into the length of this question. So they're asking you which of the following is true about basically RPGN. Okay, someone said, ma'am, when you wait for the answer, we get scared. But that's how, you know, you need to get used to it. There will be pressure on you in the exam also. So obviously that, and with no one interacting with you, you're all on your own. So yes, first and foremost, let's start reading over here. So kya likha tha? When they are asking me about RPGN, the immune complex mediated crescentric glomerulonephritis is a type 2 wala. Is type 2 associated with a linear staining? Of course not. Type 2 was associated with the starry sky. Linear is to do with type 1. So this is definitely a wrong statement. Okay, next. Antiglomerular basement membrane type 1 is associated with granular staining. Ye bhi ulta kara. Type 1 is associated with linear staining. Totally wrong again. Third, in posse immune type 3, we see deposits present. Of course not. I was happiest about posse immune कि उसमें कुछ भी नहीं है. There is nothing in it. Posse means there is less immunity. There cannot be any deposits. Again, totally wrong. The last one, is the type 3 the most common type of crescentric? Yeah, such an easy statement. Such an easy statement. That is of course the answer over here. Yes. Also another PDF students are back. PDF will be shared on Telegram, so don't worry. Yes, so I've always wondered, you guys download so many PDFs. Be honest with your hand on your heart. Do you actually revisit all those PDFs, or is it more like a mental satisfaction that whatever I had is there in my list and my that PDF book that I have almost made? Sometimes it's more of mental satisfaction, but I hope these PDFs you will get back to in the end when you need your last minute and last hour revision for that matter. Okay, having said that, chalo. This question is also sorted, but we have only done what? We have only done nephritics. Let's do a rapid revision of the nephrotics also. First wala nephrotic, I have to use that term once in every session, which is the Ghisa-Pitta question. That is the Ghisa-Pitta question. That is going to be nephrotic syndrome. That is going to be nephrotic. So yes, having said that, now the first one, obviously you can, the first picture, and that's a hint guys, there will be pictures of electron microscopy in the exam where you will feel that you have never seen them. Whenever you feel that you are a little stuck, please remember, find the feet. Find the feet whenever you feel you are stuck, because the feet will guide you to the pathology. Once you find the feet, you'll start getting oriented to the entire kidney biopsy. So in the first picture, definitely I have found the feet. But in the second picture, there are no feet. So what is that going to be? This is going to be effacement of the foot processes. This is effacement, and you know this question is all-time favorite. What disease are we talking about? Minimal change disease. What's the age group that they will give you? Minimal changes, minimal age. This is going to happen in children. This is the most common nephrotic that you see in children. Like I said, minimal age, minimal change, minimal age. That is how you learn it. There's no other gold standard. No light microscope, no immunofluorescence, no gross, nothing. Seedha, one question. That is effacement of foot processes. Coming to the next, you've done it in children. So you now have to also go ahead and tell me what is the most common nephrotic that you'll see in adults, and that is going to be FSGS. That is FSGS, focal segmental glomerulosclerosis. Can you all visualize? There is a pink deposition that has happened. That is focal segmental. Only a segment is affected. That is what is FSGS. And what is the history? FSGS ka kya history aayega? There's a very long list, but we will have to revise that list because these are 6 questions that come in the paper. HRs, that is 3-2-1, 3H2R1S, HRs, that is H for HIV, very good. HIV positive patients have FSGS. Next is hypertension patients have FSGS, amazing. Someone who's on heroin drug abuse, that is going to be FSGS. So HIV, hypertension, heroin drug abuse, all these are FSGS. What are the 2 Rs? Having any kind of reflux nephropathy and having any kind of renal tissue loss. Having reflux nephropathy and renal tissue loss, that is also going to be FSGS. And finally, the only anemia, sickle cell anemia. These are going to be 6 questions. The question will start like this, a picture of this segmental kind of an involvement will be there, and that is how you will give the answer over there. I hope that's okay with everyone. HRs ke basis pe. So instead of writing HIV, you know what they write in the paper, na? They write something called HIVAN. HIVAN is nothing but HIV associated nephropathy. It's the same thing. Can you tell me in HIV which kind of FSGS happens? Which kind of FSGS, the most deadly FSGS? Collapsing FSGS, everything, the entire glomerulus collapses. So it's simple, na? HIV is a horrible disease, of course. So the most horrible type of FSGS should happen over there. So the entire glomerulus only collapses. Collapsing type of FSGS is going to take place. So there's a question that comes pertinent to that. And this is what I was asking you. That's your PYQ. So you have to know this. HIVAN is associated with what? I know HIV associated nephropathy is FSGS. Which type of FSGS? That is the collapsing type of FSGS. So actually they ask you what is the name of this classification. Fancy names are an examiner's favorite. This is known as the Columbian classification. I don't want you to learn all 5-6 things that come under it. No, I just want you to learn 3 things that come under Columbian classification of FSGS. One is FSGS not specified. Not specified is the most common type that we have. Second is FSGS where a tiny little tip is involved, means glomerular tip. glomerular tip, when a tiny little tip is involved, I'm very happy, means it must be having a very, very good prognosis. But when the entire glomerulus has collapsed, collapsing FSGS has happened, I am not at all happy, because that is going to have a very bad prognosis, and that is the one that we see in association with HIV. So please remember, NOS is the most common, tip is the best, and collapsing means pathetic, so that is going to be very, very bad prognosis. So yes, that question seems to be done. What are we left with? Bachchon wala ho gaya and adults wala also done. What do you see in extreme elderly people? What is that nephrotic that you see in elderly people? In elderly, at very, very advanced age. So how I have learnt is, elderly means peak of the age. At peak of the age, you see something called peak pattern. What is that peak pattern? Spike and dome pattern. At the peak of the age, you see the peak of the pattern means you are talking about membranous glomerulonephropathy. Easy to learn. Peak of age, peak of pattern, spike and dome, and this should immediately remind you of that hairstyle that boys used to keep once upon a time, that porcupine spiky hairstyle. Exactly same way the kidney is going to look like. The spiky hairstyle is what it's going to show. So can you all visualize how these basement membrane is giving up spikes like this? Yes, so those projections which are going up like that spiky hairstyle, that is known as the spike and dome pattern, right? Okay, coming back. So remember, peak of age and peak of pattern, that is membranous glomerulonephropathy. And what are these last two pictures? Even by ruling out, we can do. This must be a case of MPGN type 1 and this must be a case of MPGN type 2. What do we call it? This is the update, so I want you to pay more attention. Over here you can see the basement membrane has split into two. If the basement membrane has split into two, you call it the famous tram track appearance. Tram track means railway track or tram track appearance. On the other hand, in MPGN type 2, we call it DDD. Yes, very good. Everyone started writing it. Dense deposit disease. There is a black color dense line. There is a black color dense. See, black and white photo mein there's only black and white. So if they are saying dense deposit disease, dense can only be black in color. So here you have a black color line that you have over here. But the update that I wanted to ask all of you was, what is the other name of MPGN type 2 now? It is said to be C3 related glomerulonephropathy. These patients have a factor called C3 nephritic factor is present in their blood. So it's basically a lot of C3 activation, complement system activation that occurs in these patients. That's the new name. That is what you have to know. That finishes off. I can take a sigh of relief, because the toughest part of systemic pathology, which is the images of renal path, not only tough to learn, very tough to teach also. So equally a sigh of relief for me also. But abhi the story of kidney has not finished, because one more thing you have to do. And no matter how many times I teach you these three slides, nephrotic, nephritic, in the end you will have to revise. So please save this PDF which I'll be sharing, because on your last 4-5 days are left. So ek baar once again just go through these nephritic slides, okay? What do we have in front of us? A very classical, no one's bothering to read the question because the picture is like shouting out loud. That is what? The picture is shouting out loud for the classical, yes, very good, the classical diabetes. Even otherwise, not only diabetes, it's uncontrolled diabetes, HbA1c. What else is there? She had come for a routine checkup. HbA1c is 11%, glycosuria, I can see a 3+ that is there. And what is this picture? Everything in this picture is like nodules. I can see nodules like this. I'll zoom into this picture. This is showing me nodules like this. So this is the famous KW lesion, but the factual name of this is what? It is nodular. It is nodular glomerulosclerosis. Nodular glomerulosclerosis. So something is going to be in those round balls, round nodules. They just ask you that what are they positive for. Please remember, they are past positive. So at the end of it, in the question they asked you, renal biopsy shows the following finding. What is the special stain for the same? Special stain is going to be pass. Quickly you will have to tell me the other, answer to ho gaya, very good. But you will have to tell me the other findings also. What is like the other options telling you? Zn stain, everyone knows Zn stain is what? Zn stain is acid fast. Acha, someone said how to differentiate it from amyloid. Yes, it could have been amyloid. I'm not denying it. But one thing is there that amyloid will not come as so many nodules. And if it is amyloid also, you will not just look at the history then after that. Now, this is a classical diabetes ka history that is given. If it would have been amyloid, they would have not given you only a diabetic history. Amyloidosis would have involved multiple organs of the body. Amyloid will not go and sit everywhere in the kidney. Amyloid will start sitting in the mesangium of the kidney. And for amyloid, they will have to give you a proof of Congo red after that. Yes? Okay. Having said that, Zn stain is acid fast. Everyone knows. Alcian blue, which disease of the esophagus? A for A. Alcian blue acidic mucin. Alcian blue acidic mucin, and acidic mucin means I am talking about Barrett's esophagus. So for Barrett's esophagus, Alcian blue is going to help us. Where do we study VVG? VVG is Verhoef van Giessen. VVG is Verhoef van Giessen. This is for elastic fibers. Whenever we want to study elastic fibers, we do a Verhoef van Giessen stain. So these were the other ones which have no relation with diabetes. For diabetes, you had to pick up PASS for this. Someone asked me, is this nodular glomerulosclerosis or diffuse? This is nodular. You can see na, this is that round nodules that you're forming. They are not diffuse. Would have been, you know what? Diffuse would have been everything becoming pink like this, in a like a complete washed out fill, like you filled up the entire thing with pink color. Over here you can see the nodular architecture. If you ask me in terms of what is commoner, if that was your question, more common is actually diffuse glomerulosclerosis. In diabetes, more common is diffuse, but examiner more than that asks you what is more characteristic. More characteristic of diabetes mellitus will always be your nodular glomerulosclerosis, that is KW lesion. That is always more characteristic. Okay, so diffuse is commoner, but characteristic is KW. Okay, having said that, I take this opportunity to quickly revise with you some hemat ka normal findings. Jaldi se, because TLC and platelet galat kiya to major problem in the paper. TLC, just because it was given in this question, we should quickly revise it. TLC ka normal finding 4,000 to 11,000 upper limit. That is what you learn for the exam. 4K to 11K is the normal TLC count. What is the normal platelet count? 1.5 to maximum 4.5 lakhs. Ideally it's 4, but maximum 4.5 lakhs is the normal platelet count. Learn these normal values, because of course this is something very basic. Another thing that was mentioned over here is DLC was also mentioned. Although over here everything is put up in the right order only, but jaldi se tell me what should be the order. Whenever you feel you're forgetting normal values of this neutro, lympho, mono, EO, they should be arranged in a descending order. That is the concept. From maximum to least. So यहाँ 60%, 30%, 6%, 4% matlab बढ़िया. It's very good. So remember, never let monkeys eat bananas. That's how you learn it. Never let monkeys eat bananas. Neutro, lympho, mono, EO, baso. They should be going in a descending order. So tell me, I know it's not at all related to kidney, but now we are expecting something as basic as this, especially after COVID, and that is why I'm asking you. Neutrophil, if they come increased in the paper, you will think of all kind of acute inflammations. Neutrophil comes more, you will think of all kind of acute inflammations. Lymphocytes come more, you will think of all kind of viral infections. Viral infections will come more, especially things like, other than virus, things like TB in our country also show lymphocytes. But tell me one thing, COVID is also a viral infection, but was that showing you more of the lymphocytes that you saw? Everyone's gone through that traumatic time. You know, you had a lot of questions on COVID. In COVID, there was a much variation, but in COVID, we were seeing that there was lymphopenia that was occurring. In COVID, there was lymphopenia that was occurring. Okay, Dr. Chandrakant, regarding the time for developing diabetic nephropathy, see, diabetic nephropathy more than time is associated with the whether the diabetes is controlled or uncontrolled. That is now coming across as a more specific parameter than the duration of a person suffering from diabetes. So someone having controlled diabetes for many years will not show you the nephropathy, but uncontrolled can progress very rapidly within a few years. Okay, having said that, all viruses show you more of lymphocytes, but COVID was showing you less of lymphocytes. Monocytes, as soon as they say monocytes are elevated in the blood, start thinking of malaria, guys. M for M, monocytes are elevated in malaria patient. That's going to be a very quick hint in your microbiology questions. Talking about eosinophils, you have to think of just two things. Either the patient is having some asthma type of an allergy, or if they ask me in terms of microbiology, they'll be giving me some kind of parasitic infection. Yes, some hookworm or some kind of parasitic infection is there. Finally, as soon as they say basophils are increased, basophil is going to be only and only for one very famous leukemia, and that is CML. These seem to be very basic questions, but trust me, as you solve PYQs, you will see that they are coming handy in so many places. So this is just something off the record that I wanted to tell you, which will help you in your questions and in your clinical practice, with which we also come to an end. Big sigh of relief. We thought of thyroid and nephrotic, nephritic and little bit ovarian, but we managed to finally cover the skin part of it also with bullous disorders. So yes, I'm happy. Now what you have to do is, you have to club this with the previous one. So I've not discussed brain tumors and lung in this because it would have been a total repetition and there was no point about doing that. So bas isko aur usko club karo and you are sorted. Having said that, what I'll be meeting you again, by the way, on 17th of February. 17th Feb is a single session, and I have no idea for how many minutes and hours will that go on for, because Feb 17th is your mega microbiology revision on the YouTube channel, and mega micro means 2.5 hours to hoga, where we are going to revise close to the exam all the images and whatever, with every image one quick PYQ we will discuss. And I think close to the exam, it's really going to help you because you have to flip through pages of microbiology very close to the paper because it's volatile and you tend to forget it, right? So yeah, that is going to be there on Feb 17th, and till that time, I just want all of you to survive on this. This is what you need to do. The last almost 30 days that are left, you have to go day by day. Every day you have to pick up all of your shattered confidence and your shattered pieces. You have to get yourself intact, decide what do I have to do today. बस आज का target क्या है? What is my target for the day? Today I have to study pathology, so I'm not thinking about what silly mistakes I did yesterday or what am I going to do tomorrow. My only aim is survive for the next 24 hours somehow. That is what you're going to do for the next 30 days, guys. And of course, I'll be meeting you. So in the coming days, of course, we'll be meeting on YouTube and online. That's undoubtedly, but your only thing. And at this point of time, anyone coming across to you as a negative vibe, just ignore. No negative thoughts, no negative gossip, not asking anyone for any kind of postponement and not even reading any news about it. Postponement has made a lot of students suffer, so please don't fall for that trap. Please study and only focus on yourself. Only your previous day is your competition. Yesterday, if you solved 100 questions, today you have to solve 110. It does not matter whether your friend has solved 200 or someone has done an entire grand test. You should not bother. You are your only competition at this point of time. So whatever you did yesterday, do a 5% better today. That is the target. Like I said, survive every 24 hours. Just go by that concept till your exam. So yes, I think we've covered most of it. As I said, I'm sorry if I missed out on any comments in between. So Dr. Amulya, respi and liver, I'll share a few, definitely I'll share a few things with you, links probably of the previous sessions. I can do that in case you guys are struggling with anything to do with that. Yes, so yeah, right. Thank you so much, guys. Yeah, the previous link, they're there on the same YouTube channel, guys. The FMG Marathon, that's there on the channel, and you can definitely go through those also. Okay. Thank you so much for joining in, and I'll be meeting you again on Feb 17th. Study well. All the best.